The second most common peripheral compression neuropathy is cubital tunnel syndrome. This is an injury to the ulnar nerve. The cubital tunnel sits between the medial epicondyle and the olecranon process. The ulnar nerve itself sits in the cubital tunnel. It passes behind the medial epicondyle through the cubital tunnel to rest against the posterior portion of the UCL. A triangular arcuate ligament is the roof to the cubital tunnel, and it holds the ulnar nerve in place. Normally, your ulnar nerve is going to be subjected to compression, traction, and friction forces during activities of daily living. Mechanism of injury for this syndrome includes direct trauma, a repetitive valgus overload, usually in overhead athletes, a subluxation or dislocation of the ulnar nerve due to disruption of that triangular arcuate ligament, a subluxation or dislocation of the elbow joint itself, scar tissue entrapment in the cubital tunnel, bone spurs, irregularities within the ulnar groove, a cubital valgus deformity, or a lax UCL. Signs and symptoms includes a patient complaining of a shocking sensation along the medial aspect of the elbow. There may be inflammation localized to the cubital tunnel. There is pain and tingling radiating distally throughout the ulnar nerve distribution, and the patient may lack fine motor control of the hand. Range of motion is not limited, but they may notice pain with flexion as the nerve is stretched. Special tests can include Tinel sign or an elbow flexion test, which is simply maximally flexing the elbows and holding it 3 to 5 minutes. This will produce radiating pain. During manual muscle testing, you will find that grip strength is weak. Neurovascularly, you will want to check the ulnar nerve distribution. Diagnosis may be through an X-ray or an EMG. There also may be a nerve conduction test. Treatment is generally conservative. However, for those who do not respond to conservative treatment, surgical treatments will be considered. There can be several different surgeries that occur, including a subcutaneous ulnar nerve transposition. There may be a resection of the medial epicondyle. The surgeon may deepen the cubital tunnel. You may find a flexor pronator mass ulnar nerve transposition, or there may be an inner flexor pronator mass transposition.